Friends, now we go on to the most important topics of today's CME. We have the master who's going to talk about fertility masterclass, the IVF protocols. Dr. Jatin Shah, director of the Mumbai Fertility Clinic and IVF Center, member of ISAR, Foxy, MOGS, ESHRE, and founder member of Aspire. He has established more than 20,000 pregnancies through IVF, ICSI, third-party reproduction over the 30 years. He has helped to establish IVF technology in a lot of places like Kerala, Agra, Erode, Madurai, Chennai, Pune, Bajitpur, and
This topic is because ovarian stimulation is the very foundation of ovarian stimulation, so that you get the most competent oocytes, giving you not only good genetic outcomes but even good mitochondrial integrity, so as to generate top quality embryos in good numbers, so that you have enough fresh and frozen transfers to give your patients a good cumulative high birth rate. Of course, just to divert a little, because Dr. Shanta Kumari told us about Dr. Rajiv's strong association with Hyderabad, I am also proud to say that recently my son, who is also an IVF specialist, married a lovely Telugu girl from Hyderabad at the Falaknama Palace. And Apurva, I understood most of the words that you used during your lecture, because I also hear a lot of Telugu at home now. So after that, of course, now to begin on a serious note, before you begin stimulating, you have to know what kind of patient you are dealing with. So you have to take into account her age, AMH, AFC, BMI, her previous response, is there associated PCO or endometriosis, and how is she likely to respond with your IVF treatment. And once you have put all these things together, you have to categorize her as a probable normal responder, or is she going to be a poor responder, or is she going to be a high responder. Of course, we know various factors now that AMH has which can contribute to a decline in AMH levels. We have more and more higher incidence of smoking in young girls. Please remember that both smoking and vitamin D deficiency are now known causes of low AMH levels and reduced ovarian reserves. So let's start with the biggest chunk, and I'm sure after the COVID pandemic, the biggest epidemic all of us have seen is the epidemic of poor responders. Means I don't even remember when I last saw a patient with an AMH of 2.5 or 3. Almost 90% of the patients who come to my clinic have low AMH, and therefore it became very important to really learn how to treat this very difficult group of patients. And with the new ART acts and with the huge shortage of egg donors, more and more educated patients not agreeing for egg donation, they want their own biological child, we have to find innovative ways of treating this group of patients. So you're all familiar, but for those of you who are not, to keep it simple, you have 4 groups of poor responders. So you have the Poseidon 1 and 2. These are young and old patients. They started with a normal ovarian reserve. So she had a good AMH, good antral follicle count. You thought you will get 20-25 oocytes, but you do not. So here you have 2 subdivisions. You have a subgroup 1A, where you get 4 or less oocytes, and you have a subgroup 1B, where you get 5 to 9 oocytes. So don't give up, it's not that bad. Even if you get 5 to 9 oocytes, I'll show you a very recent meta-analysis which shows that the pregnancy rate in that group is still very, very good. So you don't have to be disheartened just because instead of 20, you managed to get just 6 oocytes. So the young and old were unexpected. So obviously you didn't give them any pre-treatment, you didn't give your coenzyme Qs, you didn't give them DHEAs, you didn't give them anything, and you are stuck with a situation with a fewer number of oocytes. Then you have 3 and 4, where you know that they are poor responders. So they are young and old patients who start with a diminished ovarian reserve, low AMH, low AFC. So you are very well prepared that she is not going to respond well. You know that, okay, you have to give her good pre-treatment to ensure that she gives you an optimal number of oocytes. So why are oocyte numbers important? Does it really matter whether I get 2 oocytes or 3 oocytes or 5 oocytes? Will the live birth rate actually change? And a lot of data to show that to get 1 top quality embryo, you need at least 3 metaphase 2 or mature oocytes. So this is the importance of getting each extra egg. And you can see that as age advances, you need more and more oocytes to produce just 1 euploid embryo. So this is where the elderly age group and the Poseidon 4 will struggle, because they will have a low ovarian reserve. You have to keep stimulating them. You have to counsel them that you might need a lot of cycles before you can achieve a euploid blastocyst and have a genetically normal baby. So how do you manage Poseidon 1 and 2 in a subsequent cycle? Okay, you know that she didn't respond well and the cycle failed. So what do you have to do? And this is why the whole management strategy is towards getting those extra 1 or 2 oocytes. So there's nothing miraculous is going to happen, but you will make a significant difference if you focus on getting that 1 extra oocyte. And why? You can see with every extra oocyte that you get, there is an increase in the live birth rate. So with 1 oocyte, if you are at 4%, with 2 oocytes, you go to 9%, with 3 to 12, and so on and so forth. The 4 commonest etiological reasons for Poseidon 1 and 2. Number 1, you started with a low gonadotropin dose. Now, please don't make this basic mistake. Now, most of you use antagonist protocols. Even if she hyperstimulates, you always have the choice of an agonist trigger, freezing all the embryos. So what are you scared of? Why are you starting with 112.5 and 150 or 187.5 or 75 for that thin, lean PCOS patient where you are so scared of hyperstimulation? You don't have to fear anything. Even if she has 40, 50, 60 oocytes, nothing is going to happen to her. You just give the agonist trigger, freeze all the embryos, and give her a fantastic cumulative live birth rate. So first important thing, the starting dose should be an appropriate dose. Second, polymorphisms. Of course, we know 10 to 20% of these patients will be carriers of polymorphisms, which make the ovaries less sensitive to exogenous gonadotropins. The commonest practical problem is the third reason, and that is asynchronous follicles. And this is most commonly seen with the antagonist protocol. Patient walks in late evening on day 2. You don't want to waste that month. You feel, oh, she may go away somewhere else. So you start your FSH injections on day 2, and then you find on day 7 that one dominant follicle has raced ahead and the other follicles are smaller in size. Remember that the dominant follicle is often selected in the late luteal phase of the previous cycle. So if you are going to start on late day 2 or day 3, as we very commonly tell them, you are not going to get a synchronous cohort. One follicle will race ahead. Then if you wait for the others to grow, you will lose the best oocyte and vice versa. So you have to be very careful about ensuring synchronous follicular growth. And the fourth is, of course, what was the trigger that was used. So let's see each one individually. Remember your starting dose for all patients across all spectrums, whether it is your thin lean PCO or it is a normal responder, should be 225 if she's a normal BMI under 35 age group. If she is above 35 with a high BMI, you can start with 300 or 450 as well. You no longer have to worry about ovarian hyperstimulation. Also, if you had done your first cycle with HMG, remember one of the greatest advantages of REC FSH is that it is more potent. There are no batch-to-batch variations, and you will get a higher number of oocytes. There is no refuting that. All the Cochrane meta-analysis say final live birth rates are same, but we are not talking about live birth. We are talking about getting 3 more oocytes or 4 more oocytes in a poor responder. So this is one area where switching to REC FSH might help. And you can see papers clearly showing that 200 will give you more oocytes than 100, 225 will give you more oocytes than 150, but 300 may not necessarily give you more oocytes than 225. So in view of cost considerations, you don't have to go ballistic for each and every patient with the dose. How much do you increase in the next cycle? Oh, in the last cycle you gave her 225 and she gave you only 5 eggs. Will you jump to 450 in the next cycle? No, you will not. You just need to increase by 75, maximum 150, and you will see a significant increase in the number of oocytes that you get in the next cycle. Why is follicular synchrony so important? I already highlighted to you, and that's why pre-treatment is very, very important. And you have simple ways of pre-treating a patient before an antagonist cycle. Of course, the best way to pre-treat is to use a long agonist cycle. The gold standard down-regulation protocol, which we all started our careers with 30 years ago, is the best way to get a perfectly synchronous cohort. I'm sure all of you who have used the down-regulation will agree that there you never have a problem of one follicle shooting ahead. The day you start FSH, all follicles grow at the same pace. But for the antagonist protocol, those of you who refuse to switch to the agonist, you still have 4 options for ensuring follicular synchrony. So the first is the use of luteal estradiol valerate. And this is very simple. Just give 2 milligrams twice a day from day 25. And she will menstruate because 4 milligram is not enough to suppress menstruation, but it will suppress the selection of the dominant follicle. So that is what you want. You don't want one follicle to start growing, and that is why you will use luteal estradiol. Then she gets her menstruation, it's a Monday, you don't want to start stimulation because pickup will be next Sunday and I have to come here to give a lecture, so how do I go about it? And then you just continue estradiol till Friday. So I can keep giving estradiol valerate. Her bleeding will stop, she will have a triple line endometrium, but there will be no dominant follicle. You then start your FSH from Friday, follicles will start growing, and then you can stop estradiol valerate at that time. Some studies say you can continue it, it doesn't really matter, and that is how you will ensure follicular synchrony. Second, even simpler, like a lot of women take norethisterone just to postpone menstruation for pujas or functions and all that. It's the same thing you have to use. Give it twice a day from day 20. Minimum 7, maximum 14 days. We normally stop on a Sunday, so she bleeds on the Thursday, and Friday you will start your stimulation. So you have to have a 5-day washout, just like with the OC pills when you use norethisterone acetate. Simplest, if you just want to tide over a weekend and you don't really want to push by 1 week unless you are going for ASRM or ESHRE conferences, then you can just give the antagonist on days 2, 3 and 4. Start FSH on day 5. Restart antagonist when a follicle reaches 14 millimeter or whatever your criteria are for restarting the antagonist. And if you are a die-hard fan of OC pills and you just refuse to listen to any of my lectures that no, he doesn't know what he's talking and I will use estrogen-progesterone combination, then please go ahead, but just give it for 10 to 12 days and don't give more than that. Otherwise, you will have excessive suppression. And then if you are using a dual trigger or an agonist trigger, it might not give you an optimal outcome. So you can see here days 2, 3, 4 is the pre-treatment group, and the number of oocytes increased from 9.9 to 13.6, and that's a good increase. You got almost 4 more oocytes, and I told you every additional oocyte counts in a poor responder. So again and again I keep saying that yes, the agonist is the best, and please go back and use the agonist. You will really remember me for your poor responders because you will definitely get more eggs, you will get better embryos and a better ongoing pregnancy rate. In fact, what was the reason we gave up the agonist protocol? It was OHSS in high responders. Now, isn't high response what you want in a poor responder? And this is what we all missed, and we just switched completely to the antagonist protocol. So Sankara first showed that, of course, the agonist protocol increases the number of oocytes by 1, but that was way back. Definitely you get 3 to 5 more oocytes. You maintain low LH and progesterone levels throughout the follicular phase. Perfect synchrony, higher number of oocytes. And it's not just me saying this, a lot of studies, a lot of European centers have now started reinitiating the agonist and long protocol for poor responders, and the latest ESHRE guidelines mention that agonist and antagonist are now equally recommended for the management of poor responders. So you can see here, higher number of oocytes, higher number of embryos, and higher live birth rates with the agonist. The best control is always the patient herself. Instead of doing 500 agonists, 500 antagonists, different patients, we decided to study both protocols in the same poor responder, in the same patient. So consecutive cycles were done using a different protocol. If the first is antagonist, second is agonist, or vice versa, and you can clearly see you get 30% top quality embryos with the long agonist and HMG combination as against just 17.5% with the short antagonist protocol. So if you are going to get double the number of top quality embryos, obviously your live birth rate is going to be much better. What about polymorphisms? Of course, we know a lot of polymorphisms are there which make the ovaries insensitive. What you need to do for these patients, of course, your starting dose in the next cycle, if you have a documented polymorphism, it's easy to test now. It's 7,000 to 8,000 rupees and it's easily available. But if you don't want to test and if you just feel, okay, this patient, she had stagnant follicles at 12 to 14 mm and she's probably carrying a polymorphism, you start with a higher FSH dose. But what I prefer and what literature says, you start LH from the beginning. So don't wait for day 7, then see stagnant follicles and then add LH. You start 2:1, 3:1 ratio right from day 1 so as to not get a hypo response and get a better outcome. What about this difficult category of Poseidon 3 and 4? And again, studies have shown that the agonist is better even for this group, almost a doubling of the clinical pregnancy rate as compared to antagonist. How high should you go? I have seen centers giving 1200 IU, 800 IU, 600 IU. It's just like flogging a dead horse. You can't make it wake up. If there are no follicles, they are not going to come. So you don't need to go very high with your doses. And there are a lot of studies 10 years old studies which have clearly shown whether you give 300, 450 or 600, your final live birth rate is the same in this Poseidon's 3 and 4, where you don't have eggs and she has a very low ovarian reserve. So even the ASHRAE guidelines are very clear that increasing the dose above 300 is not really going to help. And going to 600 very often affects the zona pellucida, and then your ICSI specialist will tell you, oh, the eggs are just bursting, they're very fragile. That is usually because of overdosing with FSH and LH in these groups. So that brings us to LH. Which patients need LH supplementation? Again, all elderly women from day 1, all hypo responders, all patients with hypo, and all poor responders is the consensus as of now that LH is important, and all those debates we heard, no LH, yes LH, no LH, are now finally laid to rest. And that brings us to the trigger. Many a times you have 20 follicles, you got only 10 eggs. You had 10 eggs, you got only 3 metaphase 2s. So what do you do here? Now this is where the dual trigger comes in. Remember that HCG, when you give as a trigger, only simulates the LH peak. But when you look at a normal menstrual cycle physiology, there are both FSH and LH surges in the mid-cycle for a perfect meiotic conversion of the oocyte. And that is where the agonist trigger comes in, and that's why you need an endogenous FSH LH to be intact, and that is why you don't have to give too much of OC pill pretreatment, which will deplete the endogenous FSH LH. So here, in a dual trigger, in the agonist trigger, you are simulating both FSH and LH surges, and therefore you get a much more physiological response. You can see here, when you combine REC HCG with 0.2 milligrams of triptorelin, all the outcomes were better in this Poseidon 3 and 4 groups in this study from 2019. All of us have this mental image that HCG is the best trigger. An agonist somewhere is insufficient, the corpora lutea are not good, she will not get pregnant and so on. But there is data to the contrary now that the agonist trigger, for exactly the reason I told you that it's more physiological, actually gives you higher number of mature oocytes and blastocysts. Of course, you have to do a freeze-all, you can't do a fresh transfer when you use only an agonist trigger, but you will get, as you see here, the blue line is the frozen embryo transfer with agonist-triggered embryos. The red line is with HCG-triggered embryos, and you can clearly see higher live birth rate with agonist triggering. That brings us to one big thing, the dual stimulation, which all of us thought is some kind of magic potion for poor responders. I'll do back-to-back follicular phase stimulation, luteal phase stimulation, pile up a lot of oocytes, and get a good pregnancy. The only thing you did was commit her for 2 cycles. Did you really have any other advantage? How many of you actually went and did dual stim and still swear by it? And that is where we need to rethink. Why did dual stimulation come in? That conventional antagonist ovarian stimulation does not take full advantage of the follicular cohort. We then had studies that you will get more oocytes with luteal phase stimulation as compared to the follicular phase. We also had studies that luteal phase derived oocytes were as competent as follicular phase, and in fact, you had a higher blastulation rate and more oocytes with so-called luteal phase stimulation. Pregnancy rates were shown to be double. So with follicular phase stimulated embryos, 26%, with luteal phase stimulated, 47%. And we were so happy, oh my God, we finally have found a magic cure for these patients. They also showed no difference in euploidy rates between follicular phase and luteal phase. And clinical, obstetric and neonatal outcomes were also excellent with both the stimulated embryos. Then where is the problem? Why suddenly am I now not sounding so upbeat about dual stimulation? I just told you with the agonist trigger, you can't do fresh transfer because it causes abrupt luteolysis. You know, it has a very short half-life, and the next day, within 3 or 4 days, and in the follicular phase in a dual stim, all of you know we give the agonist trigger. Within 3 or 4 days, she menstruates, and then you start off the so-called luteal phase stimulation. So there is a twist in the tale now that we never did luteal phase stimulation. We were just doing 2 follicular phase stimulations back to back. So all this data, all these studies are now invalid because they don't make sense, because they do not represent true luteal phase stimulation. If you actually do estradiol progesterone levels 5 days after an agonist trigger, they are exactly the same as day 2 of a normal menstrual cycle. Then how are you calling it a luteal phase stimulation? Plus, now there is a lot of concern about macrosomic babies with frozen embryo transfer in the West. And with the so-called dual stimulation which we had to do frozen embryo transfers. So now the new thing, and which Polizos and Annalisa will be presenting at the ESHRE next week, I already spoke to her, the results seem to be very good, is the first stimulation starts in the luteal phase. So this is true luteal phase stimulation. You start it on day 17, 18 or 20. Give your agonist trigger, pick up the oocytes, she will menstruate, then do your follicular phase conventional antagonist protocol, give HCG trigger and do a fresh transfer with whichever embryos were of better quality, whether they were of the luteal phase or the freshly generated follicular phase. So this is how it has to be really done. Of course, they will not reveal all the success rates and everything until the paper is published next week. So I'm just eagerly awaiting the Copenhagen trip to listen to this particular, is it really going to help our poor responders? Of course, adjuvants, we are all now familiar with coenzyme Q, transdermal testosterone gels, growth hormone, of course, came and went. But now there is again a lot of renewed interest for three things. The three adjuvants which now seem to be working after a lot of to and fro. One is DHEA, which we all gave up on, saying, no, it doesn't work, it's not good, it's coming back. Second is growth hormone. We said it's too expensive, there are too many regimes, as you can see here. There are so many different ways of giving growth hormone. But again, there is rejuvenated interest. And the third, which really works well, is coenzyme Q. But you have to give it in an adequate available dose. So 100 to 200 milligrams of the active ubiquinol component must be there for you, and at least 60 days to get the right thing. So the one study about coenzyme Q which really caught my attention is, can you really turn back a biological clock with aging ovaries? And you can see here, the top ovary is a young ovary, the second ovary is an old ovary, and the third one is the old ovary. This is of course in mice after 15 weeks of coenzyme Q. So you can see that whole ovary is absolutely regenerated and as if it's become a very young ovary again. So there is definitely a ray of hope that coenzyme Q, if properly used, will give us much better results for these patients. Laboratory essentials, very important. And this is something I feel so strongly about, because most units, only 2 eggs, do ICSI. She's 37, do ICSI. What is the logic? Why? There is absolutely no logic to this. There are so many papers, and last 20 years, and just handful of us left who still do conventional IVF. Did you know that 95% of Indian units do ICSI for all, without any justification? There's more exposure to PVP, hyaluronidase, the atmosphere and everything, but yet nobody listened to me. Finally now, you have no choice but to listen to me, because this is breaking news from day before yesterday. I don't know how many of you attended this online ISAR global initiative. Valerie Baker first time released the data on 1.5 lakh infants born through IVF and ICSI, and I don't have a point. So you can see here, this is very, very important. You can see here, these are major non-chromosomal cardiovascular genitourinary. Look at the last group, that is IVF, autologous, fresh transfer, ICSI with male factor, and this is the same ICSI done without a male factor. And this is the matter of concern. You can see 1.49. If we consider natural pregnancies as 1.49 means there is a 49% higher risk of an anomaly with unindicated ICSI, and here you can see 56% higher risk of anomaly with unindicated ICSI. Now this has to be a wake-up call for all IVF centers, that please switch back to IVF if it's an IVF case, and just do ICSI where it is indicated. And of course, don't take home a wrong message. When I say 50% more, it doesn't mean 5 out of 10 babies are abnormal. If the previous risk was 2%, means 2 in 100 babies were abnormal, with ICSI you are making it 3 in 100. But in a country like us, where thousands and lakhs of IVF babies are being born, this is a hugely significant number, and it's not fair to the patient when you know that unindicated ICSI can cause concern. And in fact, the highest, I don't have all the slides with me, and it's really, really interesting. You can see here, you will have 56 more major birth defects per 10,000 babies, 91 more per 10,000 babies, and so on. And they have very clearly recommended that don't do double embryo transfer. More anomalies in twins is now proven fact. You have to do elective single embryo transfer. You have to make sure you don't do unindicated ICSI. With no male factor, you are increasing the risk by 30%. With male factor, you are increasing the risk by 42%. Of course, I asked Valerie online, what about the corrections for age and PGT and so on. So they are doing a lot of subgroup analysis now. And that brings us to the results, which I told you that do they have to despair the Poseidons 1, 2, 3, and 4. And this is the largest study published 2021 on actual pregnancy rates. And it's pretty heartening as expected. The young group, you still have a pregnancy rate of 27.8%, even if they have less than 4 eggs. So very important point here, how important age is in correlating with success rates. If you get 5 to 9 oocytes, excellent at 48%, which is the same as group 5, which is the non-Poseidon normal responder group. So these two really do well. Of course, group 2, group 3, group 4, again group 2 with 5 to 9 does well. Group 3 and group 4, as expected, still not very bad at 20%, 15%, 30%. So there is a ray of hope even for the older generation, older group of patients. So of course, they clearly showed, as I can see here, that 50% lower, just age related. The future, of course, time is running a bit short, but just quickly, intra-ovarian PRP for poor responders. This is the largest paper of 500. Fortunately, we have Dr. Rajiv here who has done the largest series in India. Personally, I find it very difficult to inject vaginally, so I still do it laparoscopically. But I'm sure the vaginal results must be equally good too. And you can see here you have an increase in antral follicle count. These are all statistically significant improvements in parameters. And mainly, the live birth rate at 34% seems to be very good, again in the younger age group. So under 38 does really well with the intraovarian PRP. But FSH should not be very high, AMH should not be very low. At least 1 or 2 antral follicles should be seen to get a successful outcome. And what if all fails? Of course, you have your famous 7 oocytes from that one altruistic donor who is donating only once in her life, only to your one blessed couple, and you are taking only 7 eggs for her, and you are not doing any commercial transaction. So that, of course, is a last hope for all these patients. And then now we've done normal and poor, now just the last category, and that is the high responder group and the PCO group. And here we know we had some major issues. The minute you would give a gonadotropin, the ovaries would explode, she would hyperstimulate, you had to cancel the cycle. This was all, of course, 10 years ago. And you also had a higher risk of early spontaneous pregnancy loss in the PCOS group. Finally, we conquered it with the 3 musketeer approach. So we know that if it's a potential high responder, you cannot touch the agonist protocol. You have to give the antagonist protocol. You cannot dream of giving her HCG or dual trigger. You have to give the agonist trigger, and you have to do freeze-all and subsequent transfer. So you can see here, again, antagonist pretreatment helps in a lot of PCO patients, especially those who have high LH or high progesterone on day 2. You can normalize the levels with just 3 days of the antagonist, and then you will get the same pregnancy rate per embryo transfer as your normal progesterone group. In this category, don't have a fixed day start. So in normal and poor, you must start antagonist on a fixed day. That is the 5th day of gonadotropins. But in PCO, you don't know when she will respond, and you don't want to suppress her further. So wait, keep giving, go from your 225, 300, 375, 400, till you see a response, and then begin giving the antagonist at, say, when you see 20, 30 follicles of 12 to 13 millimeters. Will we no longer be discussing the antagonist? Looks like, because a lot of PCOs really do well now with PPOS, that is progesterone primed ovarian stimulation. You give 10 milligrams medroxyprogesterone from day 2 along with the FSH injections, continue till the day of HCG, and because of the super maintained LH levels, you have much better outcomes. As Chen showed, it is not just suppression and reducing number of injections. Because you maintain low LH levels with progesterone as compared to your antagonist protocol, you actually have higher clinical pregnancy rate at 61% as compared to 47% in Chen's study, and they were quite a reasonable study with 300 versus 152 patients. So there is some food for thought here. You can use dihydrogesterone also if you don't want to use medroxyprogesterone. 20 milligrams is the same. And agonist trigger, as I told you, if you have given OC pill pre-treatment and over-suppressed the LH levels, you will not get an optimal response for these patients. Add back HCG doesn't really work and still gives an unacceptably high incidence of ovarian hyperstimulation at 13.6%. I already told you the agonist is of course better. And finally, of course, we have all been taught that you have to use pure FSH. You cannot give LH to PCOS patients. We just have one large trial now, and that is the Megaset HR trial, where they actually compared outcomes with REC FSH versus HPHMG in PCOS and high responders. Fresh cycle outcomes were similar, but early pregnancy loss was almost half. You can see here 14% versus 24%. Because HMG is less potent, you will get 7 fewer oocytes, translating to 5 fewer metaphase 2s, you will get 4 fewer zygotes, you will get 3 fewer blastocysts, but you will get the same number of top quality blastocysts. So that is the first point that they observed in this large study. When you look at frozen embryo transfer outcomes, again, live birth rate per FET, non-inferior, again, statistically significant reduction in early pregnancy losses. If you look at cumulative live births, that is one fresh and all frozen in 6 months, it was similar, but these were frozen embryos were all euploid, so they were PGT tested blastocysts, and they found that the same live birth rate was obtained with 43 fewer transfer procedures using 65 fewer euploid genetically tested embryos. Freeze-all, of course, this is one category where we don't have a choice, and we also know that they are prone to premature progesterone rise. The more oocytes that you have, the higher the incidence of progesterone elevation. Freeze-all will definitely take care because the high progesterone only affects endometrial receptivity and does not affect the oocyte and embryo quality. What about various phenotypes? And wonderful study by Dracopoulos and Blockhill presented at the last ESHRE that when you do freeze-all and conventional stimulation, don't do mild stimulations, letrozole stimulations, clomiphene stimulations for IVF cycles, you will find excellent cumulative live birth rate from one pickup, and all frozen transfers put together at almost 70% in all the 4 phenotypes. So today, this is the most successful method of treating any type of PCOS patients which we have. Again, a turnaround, just like no ICSI for all, and HRT FET, please don't do HRT FET for all your patients. We now have genuine concerns that 10 to 20% of patients don't produce as good an endometrium as they had in their natural stimulation cycle. Genuine concern that because you don't have a corpus luteum, because you have suppressed ovulation, higher risk of PIH and macrosomia. And just as we saw the breaking news data on ICSI causing anomalies, you may also in the future have with the same with frozen embryo transfer. So in PCO group, why I put this slide is that you can't do natural cycle because she doesn't ovulate. You don't want to do HRT cycle because of PIH. You have to do a mild ovarian stimulation and then time your transfer as per the ovulation date. This is again a very important slide. You know, most PCO patients have endometrial hyperplasia. All literature, conferences, we only keep talking of thin endometrium. Nobody talks about thick endometrium. So this is something we did at our center. We exploited the anti-estrogenic effects of clomiphene for this group of patients. So if she goes to 18-20 typical homogeneous endometrium, no triple line, just give her CC 100 or 150, days 3 to 7, add a little bit HMG, and 9 out of 10 patients, your endometrium will not cross 12 mm. You will get a perfect triple line in these patients, and you will restore your pregnancy rates. Of course, this is not yet published, but I hope once we finish 30 or 40 cases, we will publish that. It will be the first publication in the world because nobody has used anti-estrogenics of clomiphene for a thick endometrial hyperplasia in a PCOS patient. Do you need to delay FET? No, you should do immediate FET. Even in a PCO, you have aspirated 40 follicles. There are 40 corpora lutea. Don't get scared. Just start estradiol valerate on day 2 or whatever method you are following and do the transfer. And they have actual papers showing that if you do it in the immediate month following pickup, you have a much higher pregnancy rate. Of course, we already heard about metformin. And so to conclude, OC pills not recommended in PCO high responders. Antagonist protocol is the best. Addition of clomiphene, letrozole, etc. not recommended. REC, FSH and HMG equally recommended, again for the early pregnancy loss part. And routine use of adjuvant metformin. Metformin does not improve IVF outcomes unless patient has an indication for the insulin sensitizer. So this is the very line that you have to follow here. You don't have to just give metformin to every PCO, irrespective of a resistance, BMI, and past history. Addition of estradiol measurements not recommended at all. The only hormone estimations I do for my patient, AMH before starting the cycle, beta HCG on the last day. We don't check anything else. No FSH, LH, estradiol, progesterone. Nothing is required with all the modern day protocols that we have. Even if you aspirate 100 eggs with the agonist trigger, don't give keberlin, don't give albumin, nothing else is required for these patients. So I leave you all with some food for thought. Antagonist pre-treatment works very well for poor and high responders. No OC pill for any group of patient. PPOS for all PCOs to reduce the early miscarriages, because we know PCO miscarriages are more often because of mitochondrial incompetence rather than genetic reasons, so PGT is not the answer for them. Just shift to the agonist trigger totally and then try to do a good frozen transfer in a natural cycle so that you have a corpus luteum and don't increase your PIH risk, and immediate FET with mild ovarian stimulation for these patients. So once again, thank you. Thank you very much, everybody, and Ferty9. And I know I took a lot of time, but I had requested for the same, so Jyoti was very kind. She said there will be no bell, no alarm, no. That was my only condition to come here. So thank you once again. Thank you so much.